Good day, everyone. And on behalf of the entire team here, I want to welcome you again tonight to this continuing education journey in passive self-ligation, and in particular, the Damon Ultima system with us here at Ormco. For those of you who don't speak English, there is a translation for you. And if you can scan the QR code on the screen, then you can access the language of your choice. There's also a Q&A at the end of this session, so get your questions ready, drop them into the chat, and we'll get as many of them answered as we can at the end of the event. A few weeks ago, we held the first part of this current series with Dr. Stuart Frost, and he shared how to get started with Ultima. Tonight, we take one step further as we understand the power of using variable torque with Ultima treatments. Our speaker, Dr. Mike Bicknell, a certified instructor in orthodontics from Illinois, USA. He is uniquely qualified to share with you his experience as he has walked the journey from traditional twin bracket orthodontics into passive self-ligation, and he has led the way for us at Ormco in discovering what can be achieved with the Damon Ultima system. Good evening, Mike.
Hey, John, how are you? Can you hear me?
I'm good. Good to see you again, and looking forward to your session tonight. When you're ready, I'm going to hand it over to you now. Please share your screen, press play, and take it away.
All right. Well, John, thank you very much. And honestly, good evening to everybody that made time to join us for this presentation. I know that for all of you, it's probably been quite a long day, and to come home and open up your computer and continue learning about orthodontics is quite a commitment to getting better. I can tell you that it's one of the things that I love about this journey is that I've met so many people who really care so much about what we do in teeth and just our profession as a whole, that it's really inspiring, and it's made me a better person and a better orthodontist every day. So I'm really glad to be here, and hopefully I can make the most of the next 80 minutes. All right, so let's get on with this. As the title that you guys saw kind of describes, we're going to try to really lay out a way of seeing how the Damon Ultima system works. It's very difficult sometimes just to show case after case after case and not get a little bit confused on how people got from point A to point B. So my goal today is to show how variable torque systems and how specifically different ancillary adjunctive treatments can be brought into the three different phases of Damon Ultima system, and also to describe those three phases in a way that allows us to look at each case individually and truly understand what's happening at each part of the journey, because ultimately we want to get to the destination, which we'll talk about in a second. So when we look at next generation, what does that mean? Next generation just means the latest or forthcoming stage in development, right? So there could be a lot of next gen. We hear that all the time: next gen AI, next gen computers, next gen automobiles. And we have what I think we're sitting on is something that is the next gen of fixed orthodontic treatment. And hopefully at the end of 75 minutes, we'll see that. So some of you guys may have seen this. When I was in Paris last year with Dr. Frost, I was able to present to some wonderful people in the audience. And before the presentation, I was with my daughter, my wife, and my mom and my father. And my daughter, who's 5, we went to the Eiffel Tower, and immediately she saw all of these things that she couldn't do, and she got sad. I snapped this picture because I thought it was funny. She was not happy to be there. She couldn't believe that she couldn't smoke. She couldn't carry a gun. She couldn't carry some sort of bottle that looks like it's going to, do something bad. But she just said, all these rules, and she doesn't like rules. She likes to live in her own little fantasy world. So the same day after we bribed her, we said that after this, we'll go get some ice cream. Here she is eating ice cream. Now, I'm not a very big put my family on social media, so I don't run around with my phone the whole time. But this is a picture that I was able to capture, thankfully, because the look in her eyes is the same look in the eyes that we want our patients, our parents, and also ourselves and our teams to have when we're doing what we do every day. You cannot fake that. And that's that that look of just joy and wonder, right? So how do we get back to that? And I can tell you that this is how I look at things now. So I was talking to Dr. Damon about a month ago, and he was telling me about his journey when he first started orthodontics. Now, this is quite a few years before my journey. I started as an orthodontist in 2002. And yeah, I started with twins and I had to band teeth. And, I've seen a lot of transitions. But if you talk to somebody like Dr. Damon, who's been doing this for 50 years, he started with pinching bands on every tooth. And he also started then with bending every single wire. Anchorage requirements used headgear and a lot of things that were very difficult for patients to use. And what this meant was it took a lot of time. And more importantly, it took a lot of effort, a lot of pain, and sometimes it wasn't very predictable. So now let's look down at my daughter Marina's face with joy and excitement. Let's look at all of the great technologies that we have. When we look at what we're dealing with now, I mean, this is really fun, and we forget this, right? We forget that all the pioneers in our profession, all the people who laid the groundwork for where we are today, allow us to be at this point where we have beautiful fixed appliances. We have, with Spark, we have a wonderful option that's really truly meant for an orthodontist or for a professional that's really trying to gain the next level of achievement. We have this amazing metallurgy for wires. We have TADs so that we can change the anchorage game, right? We can do things that we could never really do before. And with these adjunctive treatments, we can put a rocket on our timelines. We can treat a little bit quicker. We can treat better. We can treat with less pain. There's a wonderful saying that says new capabilities emerge by having smart people with access to state-of-the-art technology. So everybody on this call right now is defined as a smart person, right? Ormco has given us state-of-the-art technology. So it's our job to put these together and come up with something that isn't really possible right now. So Thomas Edison, great inventor, said, if there's a better way to do, find it. And I really find that that's my passion right now. I'm trying to help and trying to contribute to our profession because so many people help me along the way. And when I talk to other people, I think of things I never thought about because they thought of it differently, right? And that's the whole journey that we're trying to do together. So I want to start with one little quick story. And the whole story is, what do you dream about, right? When we think about dreams, I think dreams are all about the state of life we're in, right? If I think of my 5-year-old Marina, this is probably her dream. It probably has sunshines, rainbows, puffy clouds. That's her and her brother traveling through some universe in a book, right? And I actually showed this to her and she was super happy. She's like, oh, wow, that's cute. So she's 5. Now, what about my 11-year-old son? Well, my 11-year-old son is literally obsessed with hockey. That's all he thinks about. That's all he plays. I'm sure his dream is something like this, hitting a winning shot, right? Now, what's our dream? I mean, sometimes our dream is just to hope that the teeth go in the right spot, that we don't get too many problems, and our dreams seem to get focused. And sometimes what that does is that limits our ability to bring new technologies into our tool bag because we've kind of figured it out, right? And once we kind of figure it out, even studies show this, we lose our ability to think outside the box. When we're younger, it's really easy to come up with an illogical explanation. Yet when we're older, we don't want to hear illogical explanations. We only want to hear logic. And that is why I feel a lot of us are so resistant to what we're going to see in the next 60 minutes. So I've heard that when I do anything outside the United States, people have 6 minutes and they want to see teeth. So I'm at 9 minutes. I apologize, but that was with introduction. So here's some teeth. And all joking aside, this is what we dream about, right? Now, I'm sure there's somebody on this webinar that can find fault in this, and that's okay. I can find a few. But if we can take cases like this, and it doesn't matter where it started, but if we can finish cases like this faster with no bends in the wire, that is something that's worth dreaming about. And what if we could do it over and over and over again, right? These are all individual patients treated with the Damon Ultima system with almost no bends in any of the wires, treating 30% faster than I would have treated with the system previous to this, right? They all look uniquely good, but they're all unique to themselves because you can't change somebody's morphology of their tooth too much, or their gum levels, or their smile, you can put them into a functional and beautiful occlusion. And these are all cases that we're going to go over today. So what we really need to do is we need to uncover how this technology allows us to get an amazing result, which is the destination. But we also have to put a lot of emphasis and a lot of information on how we're going to reveal a clear and easy pathway to get there. Because if something's not easier and something's not clear, then it's not going to be utilized or adapted. But if we can show an easy, clear pathway to get to these beautiful destinations, and we can do it with reproducibility, I mean, that's something really that's going to change our profession. So here's just a snapshot of some of the most recent cases that we treated. I mean, we look at every D-bond and we put them in a certain category. So these are just some of the images of the most recent D-bonds. And you can see that they all have this really nice, detailed, finished look. Now, I can tell you, very few of these have bends, and many of them are finished in copper and eye, which was not what I used to do before. So let's also look at some of the metrics, right, on the journey. In our practice, I looked at 100 cases, and on the left side, using DQ, we were averaging about 19.6 months per case with about a little over 13 visits with an average of 5 bends in each wire. If I compare that to 100 debonded Ultima cases, the average was 14 months, 9.6 visits with an average of 0.2 bends per wire. Now, what does that mean? Well, what it means is that our total treatment time for, I think, an improved result was about 28% less. The second thing is that the total visits, which is really important for people with busy schedules, and it's also important for our efficiency and our sanity. I mean, why do I want to see somebody 20 times if I can get a better result and only see them 10? You know, it is about simplicity. It is about scalability because it allows us to deploy our treatments to more people. If our offices are filled and we have an ideal of only seeing so many patients a day, well, if you have less visits, you can see more patients in a given year without seeing more patients in a day. So to me, this is quite important. The most important thing I think to everybody on this call is that 98% less bends were noticed in my practice. And this is my practice with myself and my associate treating the cases together, right? So that is insanely significant. 98% spending, and I find that the results look better. Now, what does this mean? If we could treat in less time, I do think that it's better for the overall patient health in the care. I mean, it's less gingival inflammation, it's less sensitivity, it can be less hypocalcifications, right? It's less things that can go wrong. So that's an improved patient experience. Less visits. We have more time to do things that we like. If you're somebody who needs to make sure that every single marginal region, every single contact point is perfect before you debond, and I believe that that's great. Functional occlusion is awesome. In the United States, we have a little bit of a time constraint. Some people really don't want to stick around for that. So we're balancing trying to finish it perfectly with also not getting our patients too upset. But if you have less visits, you have more time to do the things you like to do, meaning finishing. And if there's less bends, it's less force, less PDL damage. We all know that. We know that there's very few people in the world that can bend a stainless steel arch wire and understand the forces that they're actually bending. That's been proven. So if we can eliminate those bends, we can eliminate that variability. So why is the ultimate patient experience important? Not just to me, but to everybody on this call. Well, it's important because it's delivering happiness to our families. I mean, that's the reason we do what we do, right? The people who come to us want an expectation and they want to be happy. They want their smile to look nice. They want it to be functional. And if we can do that in a happy environment, that's great to all of our families. But we also want to make sure that we're doing that to our patients, right? I can make my patient's mom happy by lowering the treatment time and lowering the treatment visits. But what if I increase the pain to my patient? Well, if I can decrease the pain and decrease the comfort, now my patients have much more happiness. And let's not forget about teams. If I can simplify my approach, I can make our team members feel like they're better equipped to provide expert level care, then happiness is for our teams as well. And if we can do all three of these, we are going to have a wonderful profession moving forward. So the ultimate patient experience truly is about embracing these technologies that make it more fun for our families, our patients, and our teams. And the way we do that is by regaining control. Now, I'm going to go right into a case because I want to make sure that I'm not spending so much time on the story. This is Jessica. Jessica was a girl who came into our practice and had a chief concern of her smile and her bite. She was treated in 11 months, and I'm going to walk you through how we did this. Now, we're going to go through and break this down over the next 45 to 50 minutes, but I'm going to go through how we're going to show this case quickly. So Jessica comes in, and if we look at this, we have to talk about some sort of diagnosis. We want to choose variable torques, and we want to talk about where we're putting the braces. So I'm going to walk you through this. So to me, phase 0 is case planning and setup, right? So that is what we do as orthodontists. We have to plan cases properly. We have to diagnose. We have to know what we're doing. So in her case, when we look at this, and we can look at x-rays and CBCTs, which we take in all of our cases, but ultimately she has a constricted upper arch, an anterior and posterior crossbite, and a lateral functional shift, partially with a tongue thrust, right? Not difficult, but not easy. There's some things that are challenging in this case. If we break this down into what we use in our practice as a comprehensive aesthetic diagnosis, I take my general diagnosis and then I layer on macro, mini, and micro aesthetics, meaning the face, the smile, and the teeth. And when we do that, it allows us to uncover things that maybe we wouldn't look at as closely. For example, an incisal edge or a zenith that's on one of the gum lines, the smile arc or the smile width. So in this case, when we look at it, she's class 1. She has mild arch length discrepancy, and she's got a functional shift to the left. That functional shift, which is slightly anterior and left, is causing a partial anterior and posterior crossbite. It's also causing some asymmetry with the teeth themselves. You can see that the upper right canine is low proclined, the upper left is retroclined. So there's little things here that we have to manage. So what do we use for variable torques? Now remember, we're now moving into all variable torque, but that was about a year and a half ago. So there are some cases that are finished that have some neutral torque brackets on it. In this particular case, you can see as we go from right to left, we used a retrocline in the upper right 3 and 2 because I want to bring those in a little bit. But then on the left side, we used a procline on the canine because I want to tip that out. But what I would have done differently on the lower is I would have used retrocline in the lower 3s and procline in the lower 2 to 2. But I use neutral torque because that's what I had, and that's what I was thinking when I first was using this case. It turned out nicely, but it would have turned out a little bit better if I would have used variable torque, which we'll get into. So where did I put the brackets? And this is important. We're going to go through bracket positioning a little bit later. Where I put the brackets is where the brackets are designed to be placed. And I'm pretty methodical about where I put the brackets. It's typically as close to FA point as possible. Now, I know there's a variability of FA point if you look through the definitions, but when we're looking at FA point, typically they're about 5.5 millimeters from the incisal edge on the central, a little over 5 in the lateral, and about 5 in the canine. So you'll see through all of the cases that I present that this is where we're targeting our brackets. In the lower, we're at 5.5 on the canine and about 4.5 on the centrals and laterals. So I'll go through this and you can see this is exactly where I put the braces, and what you're going to find is a beautiful finish with no wire bends. Again, we're just basically looking from posterior to anterior. You can see that our 6 is at FA, our upper right second bicuspid is in line with the first molar. Then we start building the wedges as we move forward. So I like to show where I put the braces at the beginning because it's going to show exactly what you think is going to happen. And more importantly, as an orthodontist sitting trying to figure out how I got from point A to point B, I'm trying to show you every single step of that so that in your mind you can say, well, I can do this too. It's really easy. And it kind of is. Okay. So now what? We've talked about the diagnosis, variable torques, and ultimate bracket positioning. Now let's see what happens to Jessica. Well, Jessica was pretty unique because we went ahead, we put her braces on. And phase 1 is essentially 014, 018, and then 140275 copper NiTi, which we'll get into. But if you look at this timeline here, we put 014s in for 6 weeks. We put those wires out. We put 018s in for 6 weeks longer. And then we put the 140275 in for an additional 8 weeks. And this is what Jessica looked like at the end of 5 months. I mean, she looked pretty spot on, right? I mean, there are some things that we have to finish, but the posterior development was corrected. The crossbite was corrected. The functional shift was corrected. The anterior crossbite was corrected. The spacing was resolved from the bottom because we put light C chain on the lowers at the 140275. So that closed in 8 weeks. I mean, this is pretty incredible when you think about where we started. let's compare these two. So in 5 months, we went from left to right. And now that I see this all the time, it's not as surprising to me. But when I first saw this, I was I was shocked actually. I took pictures of it and sent it to Dr. Damon. Said, "Hey, like, look what's going on in my practice now. I hope this happens more and more." And it is beautiful posterior development, all of the control. You can see that I have a light C chain under the upper 3 to 3 and the lower 3 to 3, but you don't see rotations in the canines. It's because this is a full expression system, which we'll get into. So you can see the lower is consolidated. Everything's looking great. Nice upright buccal segments, rotations are worked out. So that's phase one. So then what do we do in phase two? Well, I'm going to try to describe this in detail, but phase two is simply moving to 180275s, gaining three-dimensional control of each tooth in the anterior, and then looking for repositions. So that's what we did. We put the 180275s in. 6 weeks after, she came back in. We repositioned the lower threes, I think, with retrocline, and we rebuild the upper left three because it was in the wrong spot. Put the 180275s back in, and here's how she came back. Not too much different than phase one, but it looks much more refined, right? You can start to see that we're expressing torque. Now the case is looking really, really quite nice, and this is only 12 weeks. So from here, what do we have left to do? Well, in Jessica's case, what we did was we took out the 180275s, and here she is in phase three, and we put in steel wires. And the reason I put steel wires in her case is I did a little bit of arch shaping, right? So I took a little bit of width. I didn't put any bends in there. All I did was shape a little bit. We finished her up with some class 2 elastics, and really phase 3 was quite short, about 8 weeks. And here's how Jessica finished. I mean, just beautiful, right? So 11 months start to finish, only 8 appointments. The wire progression on your right is what you see. Again, 014, 018, 140275, 180275, and then final wires. Our adjunctive treatment was class 2 right and left. We used quails, 2 ounces. That was it. And this is a wonderful finish. These pictures are taken 2 days after debond, right? So we're not waiting 4 months for this to settle. And you'll see there's cases where I didn't have it settled when I debonded it, but just magnificent case. And again, showing the torque selections, showing the bracket positioning, and all the phases really tries to illustrate how powerful the system is. And again, we can't forget the tenets of PSL, which is posterior arch development. If you look at this upper arch and you look at this lower arch, this is the reason why this all works out beautifully, is that we gain that beautiful natural arch form that is functional with the lower. We're coordinating those final arch wires, and it looks great. When we look at her smile transformation, it starts out a little bit inhibited and narrow, starts to get bigger and bigger, and obviously look how happy she is. Fun thing to note is that around month 9, she actually started working for us. She liked what was happening so much that she joined our team, and she's a wonderful access to it too. So many of the photos that you see today are probably taken by Jessica. So 11 months, looking great, right? So what I really want to do is show this, because this is important, right? Initial bonding, phase 3 final. Now, phase 3 is 1 week before debond. There are no bends in the wires, right? So I'm showing what's happening, and it really is quite amazing. So how does this happen? Well, first thing we have to do is we have to spend at least 3 or 4 minutes talking about why we have to work so hard to achieve excellent results. Because unless I understand why I'm having a problem now, I don't really understand how the solution is going to help me. So I really always find that I want to talk about the problem, the solution, and then we'll go through mapping on how we do this. Now, bear with me if you've seen this before. I tried to close it down a little bit, but there's a lot of people on this call that have never seen this. And it's very, very important to understand the why behind why was the Damon Ultima system invented. This is not an upgrade. It's completely different. And that why starts with a little bit of history. So Edward Engel, 1925, father of modern orthodontics. Basically, when you think about what he did in the span of his career, he started using a large wire and using steel ties wrapped around the crown of the tooth to pull the teeth towards this wire. It was called the E-arch. And then he's like, all I'm doing is tipping teeth. So he came up with a pin and tube, and then a ribbon arch, which was a tube vertical. And then eventually he settled on something that he took the slot, turned it horizontal, and shoved a wire in there, calling it standard edgewise. I didn't know this, but weirdly enough, it was 022 by 028 100 years ago. The problem is that there was nothing pre-adjusted. They were really crude appliances. The wires were marginally okay at best, and it was very, very, very painful and very, very time consuming. But that's how it was for a long time. And then Larry Andrews came around, and Larry said, "You know what? We've got good technology. I'm going to go ahead and study 120 models that have never been treated. I'm going to find some characteristic commonalities." Now, when I look at these models that have never been treated, I'm seeing certain things that look really good that help these teeth fit together beautifully. And he eventually came up with the 6 keys to occlusion. It had to do with tip, torque, rotations, axial inclination. Then what he did in his brilliance is said, why don't we build braces that have some of this built into it? And guess what? The first pre-adjusted appliance was invented. Now, the problem was that in order to get 3D control of the tooth, you had to use an 021.5 by 028 wire in an 022 by 028 slot. Larry Andrews quickly figured out that you couldn't get that wire into the slot. So the easiest way to get the wire to fit into the slot was to decrease the dimension of the wire. Now, as you decrease the dimension of the wire, you start losing control. So then Larry Andrews came up with different prescriptions of his braces based off of different cases. So if he had an extraction case, he would use an extraction prescription, knowing that he was losing control of the wire bracket interface. Hence, 30, 40 years later, why we have 30, 40 prescriptions of braces is because every bracket system that has a prescription is accounting for something that is in a form of variability between the wire and the bracket. Because there really is only true one prescription. Everybody knows it. And that's the prescription of it looking really good. That would be 7 degrees of torque in the anterior, 2, and then maybe -1 in the canine. Those are all the prescriptions of what people like. But why do we have a 22-degree incisor? It's because if you're extracting and you're getting a retroclination, and you're in class 2 and you're getting a retroclination, and you have 15 degrees of play between the wire, the hope is to end up at 7. So that's where that comes from. And it's important because that's going to help explain this. So our work is the presentation of not just our abilities, but our capabilities. And what I like to do is I really want to highlight people's talent, right? Throughout the world. I mean, I'm a geek when it comes to people's talent. So I look all over the world and I see what people are doing. And these are Instagram posts from people that are doing wonderful work. And you can see what they have to do to get first order control. There's a rotation wedge, a hard tie on the opposite bracket wing, which I've done plenty of times in twin mechanics. Second order control, you're bending a lot of wire. Third order control, you're using a Warren spring, right? So there are people that understand how to get to the final destination, but they're working so hard to get there. So to illustrate that, I want to go through 2 quick cases. And these are not ultimate cases. These are Q cases. So this is Tiffany. Tiffany was 28 when she came in. It took me 23 months to finish her. This is what I called my unicorn case. Okay. The reason I called it my unicorn case, it was one of the first cases I showed on a big stage to hundreds of people. And I was super proud of it. So I searched, I looked, and Tiffany came in class 2. She had traumatic extractions of her lower first molars when she was an adolescent. She was constricted, lips were full, would not let me take teeth out, right? The upper bicuspid extraction was a perfect route here, but she wouldn't let me do it. So I partnered with her. I said, let's use some TADs. Let's use good elastics. Let's use this fancy technology of PSL, and let's get there. And we did, right? So I was able to get from point A to point B using a lot of tools in my toolbox. But now let's look at Leonard. Leonard is another PSL case that came in with some of the same constraints. He's 31. He didn't want surgery. He didn't want extractions. And he wanted me to treat him because he said that I had good Google reviews, which is true. We do. But this is my scary unicorn case, right? And why is it scary? Because it didn't work out as well as Tiffany's. And let me show you why. Leonard was constricted skeletally. He had bilateral crossbites, a lot of crowding, upper and lower, class 3 skeletal. I mean, just all the stuff. I mean, this is a surgically assisted rapid palatal expansion case mixed with possible lower jaw surgery. Would not go for any of it. So we said, let's do what we can do. And I crossed my fingers. And this is where I ended up getting Leonard almost, right? I mean, I think he's finished now. I have to get his final updates. But But this isn't that great, right? I mean, I struggled to get here, and it still scares me because there's a lot going on here that I don't like, and I don't know how long it's going to hold up. But he loves it, which I guess helps a little bit. But let's look at this. When I pulled Leonard's wires out, and I did this for a meeting that I had. In his first order, there's 8 bends in that wire. In the second order, there's 9 bends. You're not really able to understand how many bends are in the third order, but that is me holding that wire on a torque bend that I have that is to help torque the root of that lateral incisor. Now, I don't know about you, but I'm in the United States right now, and that tooth is probably somewhere in Europe. It should be at least, right? I mean, with 50 degrees of torque on a tooth, I don't understand how that tooth is still in the arch. And who knows, maybe I've dehisced the root so much that in 5, 10, 20 years, he may end up losing it. I don't know. But I can tell you that this is super frustrating because when you have this amount of work in a wire and the wire breaks, or the bracket breaks, or your team member can't put the wire in, it gets really, really frustrating. So let's talk about why we have to do that. So we're going to go spend about 3 minutes on the inherent problem with all systems. Okay. So when we take a closer look at this, Dr. Damon says, let's fly into the slot and take a look. Now, when we look at something like a traditional design bracket, we have to assume that whether it's a twin, an ASL, or a PSL, it's all pretty much the same. It's a rectangular slot with a rectangular wire. Now, of course, an ASL pushes the wire into the base, supposedly. And of course, a twin doesn't have a fourth wall, but it's still a geometry problem that we're going to talk about. And all of this is the same. The same geometry problem happens for all systems out there currently, except for Ultima. It's some custom systems, but let's look. So if we do what Dr. Damon says, and we go ahead and we try to open up the door and we fly in, right? So we open up the door of, this is just a traditional PSL like a Q, right? Which an Q is a great bracket. We zoom in there and then we go ahead and we figure out what's happening in first, second, third order. First order is rotation, right? Or in and out. So we're going to go ahead and we're going to fly in through the wire and we're going to see what happens in that slot. Now, this is a full size wire. This is a 1925 steel in an 022 by 028 system. So in the first order, we have that much play. Well, that much play doesn't mean much. How much is that much? Well, if we go ahead and we take the cross section, we slice it down, and then we move that tooth back and forth until we hit a couple. A couple is an equal and opposite force in an opposite direction. So if we do that and then we measure the bracket and we measure the wire, we find out that there's about 4 to 5 degrees of play in one direction. So obviously, if we flip that, we've got another 4 degrees in the opposite direction. So if we look at first order play in a full dimension arch wire, we have almost 8 degrees. Now, what happens in the second order? Well, in the second order, that's tip. So we're going to go ahead and we're going to look at the horizontal surface of this wire, and we're going to move the bracket back and forth in a tipping motion. Again, 1925 in an 022 slot. If we go ahead and we open up the door and we do the exact same measurements, we're going to find out that when we tip the tooth until it hits a tipping couple or an anti-tipping couple, we're going to find that we're going to have about 5 degrees of axial play. And that's in one direction. So if we do that in the opposite direction, we get another 5 degrees. Now, interestingly enough, between 5 and 6 degrees of play is almost 1 millimeter of tooth movement, right? So we wonder why we're seeing these problems. Now let's look at third order, which is absolutely shocking once you quantify it. If we go ahead and we look at an 022 by 025 bracket around a 1925 wire, this is how much play we have in a torque direction. So if we look at the couple, we take the measurements, we find that there's 11 degrees of play in one direction, in a procline or a retrocline direction, right? So now if we have 22 degrees of play in torque, we've got 8 degrees of play in first order, 10 degrees of play in second order, and 22 in third. It's almost impossible to think that we would be frustrated, right? So if we zoom in here and we start playing with this, and we add this up and we have 8 degrees back and forth, we have 10 degrees axial, and we have 22 degrees in rotation. And again, this is twin systems, ASL and PSL, all like, it doesn't matter, right? This is the reason why we have so much inefficiency. It's the reason why we have so many people out there coming up with custom designed 3D printed bases, is because they're trying to accommodate for these geometry issues. So what happens when we have a wire bracket assembly that allows for clearance like this. We have to bend wire. So if you look at the left side timeline, that would be the case progression in months. Let's look what happens in a very common journey. In a common journey, we start out with round wires and then we have to start making bends. Now we make these bends because we have a rotation problem, so we have to bend it. But that rotation problem turns into an axial problem, so we have to bend it. Then we see a torque problem, then we bend that, which turns back into an axial problem, we bend that. And finally, we get to a point where we're either frustrated or it looks really good, and then we take the braces off. The ideal journey would be just a straight line, and it would make our treatment shorter, not because we're moving teeth faster, but because we're eliminating all of these bends and all of these times we have to self-correct. So what does that mean? Let's look at the top line. The top line is Jennifer's case that we just saw. That's the beginning and that's the end. I tried to find a DQ case that was similar, and I think I found a pretty good one. Little spacing in the bottom, posterior crossbite functional shift. That was the beginning and that was the end. Now, did I get to the final destination in that case? I think I did a reasonable job of making that case look and function properly. I personally like Jessica's case better. However, I had a lot of bends and a lot of time. Let's look at that. It took me 23 months and 13 visits to get from beginning to end using a traditional PSL bracket. And that was working really, really hard. So because of that, those little X's is more time, more visits, more effort, more pain. So we've uncovered the problem pretty well. So how is the Damon Ultima system different? Well, that would be the solution. It's pretty simple and easy, and it all is about geometry. So Dr. Damon, after many years of playing with his revisions of PSL, finally understood that he wanted to build a variable system. And by building a variable system, what he realized was he was adjusting around a center point lineup. So when in his mind, if he could develop a bracket system around one single point and develop a wire that could get you to that spot, then he would have something that was of value. And that's where this whole thing came from. The parallelogram came from having two different versions of a variable torque bracket that was superimposed on itself, right? So Dwight is an amazing inventor, and we can all thank him for this because without it, our roles would be much, much harder, right? So with this new evolution, we have quite a few contact points that keep the system passive, but allow us to have 3D control. To me, the only issue that we have right now as a barrier is we have to unlearn years of compensatory behaviors and using the systems that have been invented before. There's a funny quote that says, "Being too far ahead of your time is indistinguishable from being wrong." So here we are. You know, I don't think Dwight's wrong. I don't think Dr. Damon's wrong at all. And here's why. Let's do the exact same thing for the newly invented Ultima system. If we look at this now, we're going to do the exact same thing, but it's going to be a little faster because there's not as much play. Okay, here we go. Now, if we look at Damon Ultima and we look at first, second, and third order through the bracket slot, what we're going to do is we're going to zoom in the exact same way. So this now is what the Damon Ultima system looks like when you have an 180275 wire in the bracket, right? So when you slice it from the first order, you can see that it fits really, really well. Well, it's still passive because the way that they made these wires is they're a combination of a round and rectangular wire. They're not rounded edges. That little dot is a point contact, which leads to 1 degree of freedom in either direction. Well, how about second order? Well, in second order, if you do the exact same thing, with a variable torque system, when you measure the height of the contact points, it turns out to be 018. Now, cool part about this is that it's an 022 slot bracket, but it has an 018 contact point, which means if we're using an 180275 wire, which is shown here, and we're using a variable torque bracket, which is retrocline, you have contact points on both sides immediately. So an 180275 is like putting an 022 wire in an 022 slot. But we have the variability and the freedom of all of the room around it. Now, this is a 140275, which is going to show a little bit of freedom. And it should, because the 140275 has 4 thousandths of clearance between the contact points in a variable torque system, which is why we're going to have some axial inclination issues. So the total angulation in play is 0 degrees and a full dimension arch wire. Now, what about torque? Well, it's the same thing as second order. Since our variable torque brackets have an 018 height, then an 180275 wire is a full dimension arch wire, which means we're going to be expressing torque the minute that's put in, and it's only going to become passive when we get to the passive state of the wire, which turns out to be 7 degrees for a central incisor, 2 degrees for a lateral, and -1 for a canine. The coolest part about this also is if you're expressing torque properly, the vertical component, because it's center point lineup, is going to be dialed in spot on, which is amazing, right? Now, this is 7 degrees. Now, 7 degrees has been shown to be that perfect central incisor angulation. It was developed by Larry Andrews, right? It puts the facial axis perpendicular to your eye. So that's how it works for procline, and retrocline works the exact opposite, except you're getting palatal root torque to 7 degrees. Now, what's important to remember is this. You get an active couple until it's passive. And once you get to your desired position, the only time that couple is going to re-engage if it's the protection couple, which means if you have a procline torque bracket and you're at the perfect position, then you add a class 2 elastic, it's going to try to engage the couple, but the tooth is going to resist it with the protection couple of the torque, which is amazing. All right, so now how does that play into our story? Well, if that's our ideal journey and that's our common journey, well, how does our ideal journey shape up compared? Well, that was 11 months and 7 visits. To me, that's less time, less visits, less efforts, less pain. So we've done the solution. Now we're going to map this out and get through a bunch of teeth in the last 30 minutes. So this is important because now we get to the meat and potatoes, or the process, the journey. How do we get there? And it all comes from simplifying this management. Now, I've been using the Damon Ultima system now for almost 3 years, exclusively in my practice for almost 2. We only have about 42 cases left of EQ2. So if you ever want to come see a fully integrated Ultima practice, stop by Chicago. We're in one. We have 2 offices, treat about 600-700 cases a year. So we've got a lot of cases going. And with this, we have to have things really simplified. The way we simplify that is we break it down into 3 phases, and that's what we're going to go through right now. So phase 1. Phase 1 is very similar to what all of us do in any system. It's leveling and aligning, right? So we start with our round wires, and then we move to one rectangular wire. So in phase 1 of Ultima, we start with our round wires, we engage our 7s, we let the teeth start moving, we work on some of the rotations, and then we insert our 140275 copper NiTi. Now, the 14027 copper NiTi is a powerful wire. It has full rotation expression. It's going to get you about half the way there with axial, if not more, but it doesn't do anything for torque, okay? So the 140275 is probably not going to engage a torque couple, but if we can dial in all of first order, most of second order, we're really, really close to where our finishes are. So also what's cool is when we put our 140275 in, since it has rotational correction, we can C-chain upper and lower 3 to 3s without any sense of rotation of the canines. So let's go ahead and look at this. So here's a case that we're going to look at. She started out with a lot of crowding, so that's why I used it. I wanted to show the power of the 3D control. What happens here? Well, in phase 1, we start out with the center point lineup, right? And then 014 round copper NiTi. That 014 goes in for anywhere between 6 to 8 weeks. Until you've resolved the round wire phase. Once we get it moving, we put an 018 in and we extend those to the 7s or the second molars, and we let that upright. Now, we're not trying to rush the round wire phase because you're getting wonderful tongue movement, you're getting rotation to start a rotation correction, and you're getting buccal uprighting, right? Because you've included the lower second molars. From here, we put in our 140275, and this is where you'll see a lot of magic happen. Now remember, the 140275 is full rotation correction, which we've never had before. It's got really nice axial inclination correction, and it's probably got, and the engineering shows that it actually has more control than the 1925 did in previous versions. So you're going to find yourself looking really good out of this system, and it's because of these contact points. So in phase 1, and this is what happened to this young lady from initial to phase 1. This is after 8 weeks of the 140275. It looks really good. The front teeth are a little inclined, which we can address, which we're going to, but they started out that way. So what we want to do is let's look at some cases in phase 1. What we want to really look at in these cases that we're going to show is that rotations are fully corrected, axial tip is pretty close, arch development and buckle uprighting are really looking good. We've attempted or finished all anterior space consolidation, and the arches are leveling nicely because we're on sevens. So let's start out with this young man. He isn't very difficult, so we always like to start out with something simple, right? Now, if we look at his day of bonding, here's where we put his braces. And I want you guys to see where the braces were placed, okay? So 5.5 millimeters from the size of the ledge, 5 on the lateral, and 5 on the canine. And I'm going to go through these not super slowly because I have a lot to show, but what I want you to see, and I hope you see this over the next 4 to 5 cases that I show, is that the bracket positioning is as consistent as I can make it. Between myself and my associate, Dr. Monika Agarwal, we put brackets on almost exactly the same, and it's almost similar on every single patient, which we'll talk about. There's no cheating of brackets. You don't have to put them mesial or distal. You don't have to cheat for axial inclination anymore. You put them right in the middle of FA point. So, it looks nice, right? So here we go in phase 1. It took 5 months, right? So 0-4, 0-8, 140275. This case looks great. You can see I've taken care of all space consolidation in the anterior. I've got a little bit of arch leveling and I'm done. And you can see that, right? And this is what you'll start to see really clearly on your cases is that they look really good out of phase 1. Now, most of the issues that I see out of my phase 1, I can figure out what the problem is. It's typically a bracket positioning issue, or it's glue under I have under the bracket base. Even right here, you can see that one. That's not fully derotated, but it's because my bracket isn't on properly. I didn't see that until later on, and that should just be a repo, and that'll take care of that. Let's look at a spacing case, right? Spacing cases are actually quite difficult because when you have so much variability between the bracket and the wire, as you close space, bad things happen, right? They tip, they twist, they rotate, torque becomes an issue. Let's look at this young lady. So phase 1, we used procline brackets because we wanted to hold the angulation, 5.5 on the central, 5 on the lateral, 5 on the canine. And here we go, right? So we have same bracket positioning. I mean, it looks very similar to the last 2 cases that I've showed you. Nothing's cheating. We're directly in the middle. We're really trying to put these brackets on the way that it's designed. And here she is after phase 1 of 5 months. So it went 0-4, 0-8, 140275. We put light C chain upper and lower 3-3. And now it's basically closing the alpha and beta segment, right? So again, looking really nice, right? You can see how nicely these teeth travel through this wire because it's point contact. Remember, this isn't a big rectangular wire. This is a rounded wire in the first order. So it's tapping across the point contact, which is why we see so much space closure so quickly. And it happens really, really nicely too. So a young man who has a little more crowding. So you can see that we know that we need arch development. We want to create space for that upper left canine. So we also know that we're going to have some, we want to resist flaring on the lower. So in this case, we use some retrocline brackets. Again, 5.5 on the centrals, 5 on the laterals, and 5 on the canine. And we started out, and what we did was we used light open coil to create space for the canine, probably an 0-3 copper knot tie in the lower. And you can see the bracket position looks pretty standard as far as how we do this. Now, we create space with the open coil. We use an 0-3. We're not trying to rush the system, right? We want to let things happen naturally. But you can see at 12 months, we've actually pretty much gotten where we need to go. Now, it may have taken me 12 months to get out of phase 1, but the cool part is there's not much left to do. So I'll be able to finish this case in the next 4 months. So it'll be a 16-month case, which is really quite nice. So if we look at the initial, you can see where we ended up. Now, what's neat about this is I can go and show case after case after case after case. Almost every single one that I've completed now, I'm always blown away by the phase 1. We have 2 more because I want to get to some, but this is a fun case. It's a class 3 bilateral crossbite and an underbite, right? He's going to start transverse elastics, which doesn't help my class 3. So we used procline on the upper, retrocline on the lower, because we know we're going to have a lot of class 3 elastics. Again, I'm not cheating bracket position, 5.5 on the central. I'm trying to find FA point each time, right? And you look at this, you can see what the wire is probably going to do. Now, he did help us out with elastics. He wore posterior crossbites and class 3s, but look where he is in 7 months. I mean, we now only have to deal with the posterior crossbite in the 6 and the 7 region. And if for some reason a case like this, I can't fix the 7 crossbite, I still think I did a great job on him, right? Seeing where he started and where he's finishing, this is unbelievable, right? He's wearing his elastics. They're only 2 ounces, and we're seeing this wonderful arch development and this beautiful control of the teeth, which isn't what I've usually used to seeing. Okay. Now, what about a case that has a lot of crowding, or a class 2 deep bite case? Here's a young lady. She has a class 2 deep bite. Again, we put on Procline in the upper because I want to maintain torque when we're using class 2 elastics, but I don't cheat the bracket right at FA point. We're at 5.5 and 5. And you can see that this bracket positioning looks pretty good. Now, in this particular case, we started elastics a little bit earlier because we did on our sister. We are now starting our elastics a couple appointments in, waiting until the 140275s. But you can see phase 1, 7 months. She's already about halfway corrected with her class 2. Arch development looks good, and it looks really, really nice. This is probably now going to be about a 14-month case, which is pretty crazy for a full step class 2 constricted. She had a crossbite there on the upper left bicuspid. That's gone because of the wonderful arch uprighting. Now all we have to do is level that arch and finish the class 2, which, again, when you start seeing this, you'll start to see how they finish out. Last one for phase 1. Again, we're not making teeth move faster. What we're trying to do is we're just trying to not be inefficient. So in this case, we used a lot of open coil springs because she had a lot of crowding. Her mom was very sensitive to flared teeth. She didn't want extractions. So we had to really use the most of the system. Light NiTi coil expansion allows for good buccal development because we're not overpowering the front teeth. And that's important. So you can see that bracket positioning is looking pretty nice. We went ahead and grabbed these teeth as we made room. And phase 1, looking really nice. Now, the error here was that my canines, I bonded them too quickly. I wish I would have modified the incisal edge, put those canine brackets up a little bit higher, and it would have finished out beautifully, but I didn't catch that. Again, when you review every single one of your cases, you start seeing things. And I highly suggest that you do that. But look, phase 1, 12 months, we took a case that was probably estimated for extractions and 24 months of treatment in other offices to something that now is going to finish in 16, 17 months. Non-extraction, beautiful outcome. The teeth are not flared. Her lips look great. Everything looks beautiful and healthy. So key phase 1 takeaways. Don't rush the round wires. Okay. Let them work. You get beautiful buckle uprighting. You're going to spend so much less time finishing that you don't need to rush to the end. Just let them work. Second, extend your O&H to the 7s when you can, upper and lower. Controlling the 7s really helps the cases out beautifully because it gives you, 1, posterior development, 2, gives you leverage for leveling lower arches. 3, anterior space closure, start that on the 140275 with light C-chain. So in summary, the wire sequence, 014, 018, 140275, that's phase 1. So now we're not going to go through phase 2 and phase 3 as detailed. I wanted you guys to see bracket positioning, but we are going to hit some cases. So phase 2. Phase 2 is when we progress from 140275 into 180275. That's it. Phase 2 is the cleanest phase of all of them because you're removing one NiTi wire and you're putting in another one. The only thing we do in phase 2 is we set up a 6-week appointment for repo, and then 6 weeks later, we set them up for phase 3, which is your final wire selection. So it's really cool. In phase 2, you're finishing up axial inclination, you're holding rotation, and you're beginning to activate your torque. And this is why. When you look at phase 2, we have our 140275 in. All we're going to do is we're going to replace that with our 180275. But now you can see that we're picking up those axial contacts, right, on the variable torque system. And this is why a variable torque system is so important. If this is a neutral torque bracket, we wouldn't be picking up those contacts because it's 022 in height. But because this is variable torque, we actually pick those up right there, right? And that's why, because it's 018. That allows us to get this tooth exactly where we want it at 7 degrees, which in this case is super cool because in my round wire phase in phase 1, I actually probably incline these teeth a little bit forward, right? But look what happened in phase 2. In 12 weeks, you can already start seeing the uprighting. The torque couple is really active. You can feel it when you put these wires in. So an 180275 in the upper and lower really engages the anterior teeth and started uprighting them. So let's go ahead and look at a couple cases in phase 2. By this time, we should have maintained our rotations, axial tip is completed, third order is on its way, and arch leveling is almost done. Okay, so here's a young lady, just had some minor open bite issues. She had good arch development. That's why I wanted to show this. But you can see 014, 018, 14075, we're at 5 months. Phase 2 should be 3 months later, right? So we put the wires in, we repoed, and then took them out at 8 months. And then she progressed into phase 3. This young guy, again, same thing. He, excuse me, been fighting a little bit of a cold. So this is the best I've talked in like 3 days. Sorry about that. Anyway, open bite case a little bit. So we put in his wires, 014, 018, 1400275. Then we go to 180275. 6 weeks in, we repo, and then here's where he is at 8 months. This is the day that we put in his steel wires to begin retraction. But you can tell, I mean, he's looking great, and this case is on its way. Here's a really deep bite class 2. You know, it's a Div 2 case, so these teeth are angulated. They're retroplined. The lower teeth has a lot of curved speed we have to level, so we know those are going to flare a little bit. That's why we use retro on the lower. So at 6 months, we started with an 013, went to 014, 018, 1400275. 6 months, it looks good. We pull out the wires, we put our 180275s in, and we left those in for an extra month. And here she is at 10 months. Now, if I look at this, we added our class 2 elastics at 140275. From here, once we level that lower arch and she continues to do what she's doing with her elastics, this case is done in another 6 months, which is unbelievable because this is about a 24-month case in my practice previous to Ultimo. This young lady was getting married in 7 months and she didn't like her teeth. She said they were flared. Interestingly enough, I'm like, well, I have this new tool in my toolbox. It has really good torque control. Let's kind of ramp this thing up. So we started with an 018 in her case, went to 140275. That's why in 3 months we're in phase 1. Then we went ahead and put our 180275s in, repoed at 5, and we finished her in 7 months with a 10-degree angulation change in her incisor angle, and a much better, broader finish. She just loved it, which was great. I know in a lot of European countries, especially in the United States too, we have a lot of class 2. So this is a pretty tough class 2 Div 2. Even her face, her chin is really prominent, which means I'm not going to get any help from a mandibular trap. So this is a lot of hard work for her. But we also can see what this does. In 7 months, we've already got arch development, 50% class 2 correction. Now we're at 12 months. You can see we're about 30%, 40% left on the right, 50% on the left. This is going to be about 17, 18 months and we'll be finished. We even have space up here, right? So as we start to retract that space, you can see the buccal segments down here are looking pretty good. As long as she continues her drive with her elastics, she'll finish nicely. And this was just to give you an update on that young lady I showed before. When I said she'd be on 16, here she is. So this was phase 1, 7 months. Here she is at phase 2 at 11. I just saw her recently. She's at 14 months and she's pretty much finished up, right? So I'll be able to show her completed in 16 months, which is tough for a case like that. So phase 2 takeaway. Give the 180275 12 full weeks to express tip and torque. I'm a firm believer, and the math and engineering shows, to repo in the middle of that timeline. So after 6 weeks of the 180275 is when I think it makes sense to repo. And I also believe the engineering supports that. Now, granted, if I see a bracket that's completely in the wrong spot and I'm in my 018, I'm going to take that bracket off right when I see it and put it on the right spot. So when I'm talking about repos, I'm not talking about gross bracket positioning errors. I'm talking about really, really, really fine detailed bracket positioning movements. If you see a tooth that's in the bracket that's in the wrong spot, immediately take it off and put it on. But we do look at a final pan repo appointment as being kind of our detailing appointment. Reposition and or reselect. Arch leveling and AP occur nicely in phase 2. So if we have to really specify phase 2, it's pretty easy. The purpose is just arch development, axial inclination, and torque. It's an 180275 for 12 weeks. So what do we have left to do in phase 3? Well, if we're in a full dimension arch wire, phase 3 becomes very, very intuitive. It really does. And let me explain. In phase 3, we just need to apply forces that get us to the finish, which means if we have a full dimension arch wire and the teeth look great, then we don't have much to do. We're kind of done. If we have to close spaces, maybe we'll go to steel wires. If we need to develop the arch with reshaping, we'll use a steel wire and we'll reshape. And I have a couple other tricks we'll talk about in a second. So when we look at final tooth positioning and we look at torque teaming, where we have retrocline and procline on different teeth, they work together. But what's cool about it is they don't overcompensate. As long as you stay at an 180275 wire, you cannot overexpress the torque, which means the prescription ends at 7, whether it's pro or retro. The prescription ends at 2 on the lateral and -1 on the canine. This is why you hear people like myself or Dr. Damon or Dr. Frost saying that it's a safe system. No longer are the days where you have a pro against a retro or a high against a low and you worry about the root going through the cortical plate. As long as you stay in a full dimension arch wire, which is 180275, that can't and won't happen. So when we look at this case, our phase 3, we went ahead and we finished this with a little bit of a bigger wire, but you can see the beautiful uprighting we got from the torque expression finished out through phase 3. This case looked beautiful when we were done. A week later, we took the braces off, and this is what it looks like, right? So this is a girl who had almost 11 millimeters of crowding in the upper and lower, started out protrusive, and we were able to finish her with an interincisal angle that was less than she started, with an AP position exactly where it began, right? So it was all posterior development, looked beautiful. So let's look at some cases treated to phase 3. We have about 16, 17 minutes left, and then we'll get to questions and answers. I'm going to hopefully get through as much as I can. So here's this case that we're talking about, okay? So she has a lot of crowding. I mean, she really does. If you really add it up, and I've done this multiple times, there's a tremendous amount of crowding in the bottom, and there's a decent amount on the top. She is only partially class 2, but she doesn't have, she's already inclined forward. So how does this look? I want you to see this in each phase. Day of bonding, we use retrocline brackets because there's a lot of arch leveling, lots of crowding. I think I measured it about 11 millimeters in the lower and about 9 in the upper. There's phase 1. You can see that we've resolved everything, but I didn't get as much arch development as I wanted. And I think the reason for that was I started by engaging those anterior teeth. I wanted to use an open coil, but try putting an open coil spring on the front tooth of a 14-year-old girl and didn't fly. So I put the bracket on and just put an 0-3 in, knowing, and I trusted the technology that I could actually get there. So in 7 months, she's looking pretty good. So in 9 months, now you can start seeing uprighting because we put the 180275 in. In phase 3, we left that wire in and we actually went to a little bit of a bigger wire to express some more torque called an overdrive wire, which, that's later down the road for anyone who's just starting. But we've got this cool tool in our toolbox that if we use a vertical wire that's a little bit higher, we can express more torque. It comes with definitely knowing what you're seeing, what you're doing with the full dimension arch wire before you use it. But 14 months looked beautiful, right? This young lady came in very highly aesthetic driven, came to us because she knew that we did aesthetic work and had a timeline of like 11 or 12 months, which we hit. So you can see phase 1 ended in 140275. She was ecstatic what was happening. A couple months later, we're in 180275 repoed. Now we had to finish with some arch development. We used stainless steel. She loved the development, finished in 10 months, and she made her day in 11 months, which was great. Beautiful result. She loved it. This young lady, crowding, has a little class 2 crossbite on the left. Again, we're going to start a crossbite elastic. I'm fine with that. Open coils to create space. Phase 1 is 8 months because it took us some time to create space for those teeth, and that's okay. But look where we are now. Crossbite's almost corrected. Overbite's looking good. Alignment's looking pretty nice. And we're only 8 months down the road. So we went ahead and we put in our 180275s, left those in for 3 months. We repositioned a couple brackets, and now we're at 11 months. 16 months, looking good, and 16 months total. Now, interestingly enough, you can always pick things apart, but if you really look at the canines, if I would have put those up a little bit more gingival and polished the cusp tip, I would have sat those down a little bit better. And those are things that you see. But what I'm trying to show you is just how, and remember, these are without bending wire, right? And I did a lot of bending. So what I'm trying to show you is consistency and timeline in phases. This young lady came in, same thing, lower lip eversion, decent amount of overjet. She actually was about 40% class 2, but she was shifting forward in some of the photos. But again, same thing, create space, arch develop, let the wires work. So phase 1 took 10 months. So now we're going to come out of 140275. Excuse me. We're going to go into 180275. We left those in for a little while because we wanted some arch development. We had to repo twice in her case to get these where we wanted them. Took those out, finished in 19 months with an 180275 steel over 160275 steel. She worked really, really hard, looked really, really nice. For some people, we have a high aesthetic practice. So in the meantime, until Ultima Clear comes out, we're using some DQ2 Ultima or DQ2 Clear in our adult cases that aren't aligners. There are some tricks to it. Just remember that you can use Ultima wires with Q2 Clear, but not with metal. There's more play in the Q2 Clear. So we only use upper 3 to 3. I don't want to confuse anyone. Try not to mix and match them, but you have to do in certain cases. But here's how it pulled out. Full step class 2 div 2 case. Here's the day of bonding. Phase 1 was 140275 over 140275, 6 months. She's wearing her class 2 elastics like really, really great. We're in 180275. She's at 9 months. She's still wearing her rubber bands, but we haven't gotten that arch development yet. So we went ahead, we moved into steel wires. We got the arch development we needed. Then she's wearing her class 2 elastics, and look how well this started trading out. So beautiful full step class 2 correction, 14 months. I did have to detail a little bit. So I took the 180275 out, the steel out at the last week, put in an 180275 TMA, and I detailed the TMA slightly to get the teeth exactly where I wanted. Okay. That's just because you still have play. One last class 2 case, because I know class 2s are what was on the hit list. This young lady, she forgot how to brush, but she definitely wore her rubber bands at the backhand of treatment. First phase, second phase. Again, we almost debonded her, but this was a little bit during COVID. She started wearing her rubber bands and brushing her teeth, and look how much this corrected. 13 months, and here she was at 14, right? So we're starting to see the power of this system. One last one. We're at 1 hour, 7 minutes. Okay. So this one was really interesting. She came in, she was class 3 crossbite, functional shift, and constricted. And this was just a joy to treat. She wore her rubber bands beautifully. We used Procline upper and lower Retrocline upper and lower for different reasons. Procline in the canines. She wore crossbite elastics in class 3s. You can see how well she wore her rubber bands. Look at the space that she generated between the 3 and the 4 during the posterior development. We were able to transition to steel wires at phase 2, close up the space, 10 months. And here she is at 13 months, and we were able to debond her pretty nicely in 13 months, right? So that was a really tremendous case that treated out beautifully. So remember, in phase 3, finishing is not detailing. Choose the final wire set that's indicated for your objectives. And because we have more time, you don't always need to use it, right? You can actually debond. So what you can look at now is phase 3 is finishing wires. Now, the options that you have are these. Number 1, if your case looks good and it's a NiTi, just debond it. Don't mess with it. If your case needs something, you have space closure, you have to develop the arches, you've got something that does not require bending, okay, then use steel. And later on in more advanced courses, we're going to get into what the NiTi overdrive wires do. But if you have to add anterior torque, the option 3 of the NiTis are quite nice. So aside from the precise engineering, what's the magic that allows this new technology to treat the result in beautiful finishes with no wire bending? Well, one of the things that I do is I do this whole thing where I talk about how Walt Disney says that there's no magic in magic, it's all in the details. So I want to go through one segment of these 6. Okay. So I don't have time to do bracket positioning today or expanded diagnosis, but I do want to do torque selection. So when I'm looking at torque selection, because I think it's important, we have to remember that we have options. We have retrocline, neutral, and procline. Retrocline is exactly what it means. It means that it's going to prevent proclination by giving you a retroclined torque couple. Okay. Neutral just means that it's not going to give you anything unless you're in the extremes. And procline means that it's going to procline your teeth. I'm sorry, it's going to give you a retroclining protection couple by keeping your teeth proclined at 7 degrees, right? So it will move the teeth to 7 and then stop. And then it will only activate if something tries to move it less than 7, right? Now, here's what the difference is. If you look at any sort of PSL on your left, it's this one right here. This is a 1925. So when you look at, when you look at all of the room around this, it's the reason why we don't have control. If you look at neutral torque, the only true control you're getting that's different is your first order. So in second and third order, you're pretty much the exact same, which is why we all make a case for using variable torque in the anterior without doubt. I don't have any neutral torque brackets in my practice anymore because I want this level of control. So torque teaming just means that when you take a pro and a retro next to each other, the geometry switches, so you'll actually see better correction in your round wires. But what it really means is when you get to your final wire, you're going to get one bracket twisting the other bracket so that they can become neutral. Remember, the system wants to become passive. So for torque selections, let's look at proclined. If we take this young lady, we know that when we put braces on, we're going to get arch development. We also know that we're going to get eruption of the incisors, which is going to cause retroclination. So if we look at the force resultant vectors, the front teeth, because we're going to expand, excuse me, and we're going to erupt, the anterior teeth are going to retrocline. So we want to prevent that by putting a proclining bracket on. That's going to prevent these teeth from moving back from beneath a 7-degree inclination, right? So what do? It's what we used. We used procline in this case, right? So let's look at this guy. This guy, we use retrocline. Now, why? Well, if we take him and we see that we know we're going to get arch development, but even with his arch development, we know that these teeth are going to procline. There's just not enough arch development there. We're not going to IPR. We're not going to extract, at least initially. So if we know that we're going to get advancement of incisors, and we also know that these teeth are going out, they're already inclined labially, we want to find a way that we can counteract that. So we're going to use a retroclining bracket, which is going to try to upright those canines to 1 degree or -1 degree and then prevent them from going forward. Same things with the anteriors. So in this case, we would choose retrocline brackets on the upper. The reason we use procline on the lower ones is because that one already had some gingival recession and I didn't want to knock the root into the cortical plate. So we used procline in the lower 3s, retro lower 2s, pro lower 1s. So what about torque teaming? Well, torque teaming is this young lady. And this young lady, we know we're going to get posterior development. And we also know we're going to get extrusion of the canines, but we also want advancement of the incisors. So what do? Well, in a case like this, we're going to go ahead and we're going to use procline in the canines, procline in the centrals, retrocline in the laterals. Those are going to work beautifully against one another so that the teeth will end up really in a great spot. In the lower, we want the lower canines to upright. We want the lower incisors to move forward, but we also want these lower lateral roots to move forward. So that's why we use those. I'm going to skip this really quick and get to the last part. Sorry, guys. Here. Okay. Because excuse me, probably to cram too many things into one lecture, and also because we only have 75 to 80 minutes, and I want to leave plenty of time for questions. And right now we're at 74 minutes. I want to end this with something that I think is really powerful. Okay. There are so many cool things that we could talk about. And I think that your journey of getting inspired by this technology comes from things that I'm going to show you. I recently presented at the Invista Summit in Las Vegas. And I was in a room of orthodontists. There were a couple hundred orthodontists in there, and I asked everybody that does gummy smile treatments to raise their hand, and there were only a few. And I could tell you, I think the gummy smile treatment's cool, but that's not. I'm not trying to show this because it's cool. I'm showing it because it's going to very much exemplify everything that we've talked about for the last 70 minutes. So if gummy smile treatment is all the rage, why is it so scary to offer it? Because I mean, whether you're in Germany, whether you're in South America, whether you're in the United States, whether you're in the Middle East, or whether you're in, Asia, there are people that have gummy smiles and there are solutions for it. So why do so few people offer it? Well, so few people offer it because it's challenging. If you take this young lad, right? You've got to diagnose and then you have to discuss it, which means you have to raise it. Then you got to set expectations because you may or may not get there. You got to put your bonding on right. You have to find out if it's predictable. You got to place your TADs. You have to activate TADs and then you create an open bite, right? Nobody likes open bites. You create an open bite and then you have to rely on your patient to close it, and that's scary. So you have to add elastics. Then you think you're almost done, but you got to pull a laser out and you got to start trimming tissue, which that again scares orthodontists. And then maybe when you finish all this, it looks funky, but you have something that looks beautiful, right? So people can show these wonderful results. And it does show some power of what we can do, but not everybody jumps on it. And I was one of them. I mean, about 7 years ago, I saw Dr. Frost show a gummy smile, and I was like, man, now I have to do this because I can't unsee it. So if that seemed like a lot of fun, why is it not common treatment in our profession? And it's because there's a lot of procedures. It's unpredictable. There's a lot of appointments, increased time. It's invasive. You have to give shots. You have to put in TADs, and you have to see blood. All of those things aside, it's hard because when you intrude teeth on a system that doesn't have control, the teeth do really funky things. And whenever I did gummy smile treatments before Ultima, when I would use my laser to cut back the tissues, I would see a lot of work I had to do with detailing the teeth to get them back into a level that it looked good. So let's go ahead and see how this works with Ultima. So these are two of my gummy smile treated cases in Ultima. You've got Pedro on the left, you've got Ashley on the right. Now, what I want to do is I want to show you these consecutively because I picked out, I was going to compare a gummy smile treatment with Ultima to a gummy smile treatment with Q. And my wife was like, well, why would you do that? She's like, you don't even talk about Q anymore. She goes, why don't you just show another Ultima case? And it was cool because that dawned on me that I would rather show something more than the sample of one. If I can show two cases of Ultima that treated out almost the same in the same timeline, it's really interesting. So let's see what happened with Pedro and Ashley. So let's look at these two gummy smile treatments. Pedro comes in, he's got a pretty reasonable occlusion, but he's got a really gummy smile. Ashley comes in and she's got a mess. She's got a really gummy smile. There's a tooth hiding back there that's over erupted almost 7 millimeters. It's the upper left second molar, right? Which I'll show you in a second. She works for me, Ashley, and she sees what we do with gummy smile. So she says, hey, can you fix this? It's something that's always been a concern for me. So we do. So let's look at these consecutively. So Pedro's bonding, we put his braces on, right? Now you can see here that the bondings look very similar, right? We didn't necessarily bond them any different than we bond a normal case. It's FA point. We didn't bond them too high. We didn't bond them too low. We want these teeth to look beautiful when we're done, and we're going to try to fix the bone around it. So both cases look pretty decent. With Ashley's, we put her braces on with an 018 because she wanted me to get going. But you can see that little molar back there. That thing's down really, really far. I thought it was going to get extracted, but I just told her that maybe I'll extract it by intruding it. But either way, let's see what happens. We activated the TADs. Let's see how this goes. So here's Pedro in phase 1, and here's Ashley in phase 1. Now, in phase 1, I pretty much expect that my gummy smile is almost treated because I'm in my 140275. You can see that his gummy smile is treated, and Ashley's is on her way, and that molar is really looking pretty good. So, but I've created open bite, right? And in Ashley's, I've created open bite as well. You can see that this molar is looking good. This is looking nice, and her smile is starting to improve. From here, I tie off the TADs because I like where the central incisor is positioned now. I don't like where the central incisor is yet, so I'm going to continue to activate TADs in Ashley's cases. So in phase 2, since I activated the TADs, Pedro wore his rubber bands vertically and settled the occlusion. So now the TADs are finished. We haven't lost any of the vertical intrusion that we got on his front teeth. And all we've done is settle his occlusion. Ashley now is tied off. That molar is almost up, and I'm still tying the posterior because I want to close this bite a little bit. But I've actually over intruded Ashley here. So you can see I've almost flattened her smile arc a little bit. So I actually released these TADs recently to let those come back down. But now let's look. So there's Pedro, and then there's Ashley. When I cut these tissues back, I was shocked. The teeth look beautiful. My first, second, third order is fully dialed in because I'm in my 180275, and Ashley, I'm in an overdrive wire because I'm trying to correct for some flaring. But this to me was crazy. So Pedro, I saw this and I'm like, Pedro, you look great. You want to get your braces off next week? So I set him up to get his braces off the week after I trimmed his tissues. Phase 3 photos were taken. The 1 week, you can actually see in his phase three photos, there's still some healing. So that's 1 week later. I took the scan. Everything looks good. This is This is the day that I did the laser gingival for Ashley. Now let's look at Pedro's final. Pedro's final looks awesome. Trita's got me smile, super happy, both elevated smiles. And look at Ashley. Ashley is almost done, right? All I have to do is settle the occlusion, take care of that molar in the back. So a couple months from now, she's finished. So here's the really exciting part. The really exciting part is that Pedro took 9 months and 8 visits with no wire bends, and Ashley took 9 months and 8 visits and no wire bends to get to the exact same spot. No longer is this something that is so out of the norm that people can't do it. If you get comfortable with Ultima, you get comfortable with the wires, really it's 4 TADs and a laser. And even if you don't do Gummy Smile, this shows the power of what we're dealing with now. I now can look at my Gummy Smile cases and say, hey, look, 12 to 14 months max, we're done. And that was something that I used to have to tell people it was 24 months, 4 TADs, maybe more. And it was just harder to kind of get my head around. And these cases are showing it that it's very easy and very fun. And this is going to be the new norm. So I think that everyone on this call should be on the side of change. The last little value prop I think that we have is this. It's easier to get beautiful, functional, refined results. Who doesn't like easy? The team. The team absolutely loves having non-bent wires. It makes them much better at what they do. It makes them experts, and they don't hurt the patients. To the media, I've never seen so much word of mouth in our practice about reduced treatment times and reduced appointments. And lastly, for me, the day is more relaxed. It's easy, fun, and rewarding. Steve Jobs said simple can be harder than complex. You don't have to work hard to get your simple clean and simple. We have these cool treatment plans. Basically, these are all downloadable resources that you guys can use. I've published a lot of different resources, and I want you guys to have this. It's quite nice. It basically just shows everything that we do from phase 1, phase 2, and phase 3. We've got some other things on there as far as bonding cards. Please, take this QR code, follow us on Instagram. In our Instagram, there's a link tree. Link tree basically is right under the bio. When you click on that, you're going to click Speaking Engagements. Speaking Engagements has a password protected area. It's restricted. That password is Chicago. When you hit Chicago, it's going to open you up to a Dropbox folder that has a lot of resources. They're all for you to download. The reason that they're password protected is because there's patient stuff on there. But please use it. Please share it. It's a lot of fun. And more importantly, if you follow us on Instagram, we're going to be coming up with a lot more free and shared resources. So that's the fastest way for me to let anybody know that we've updated our link tree is through our Instagram. So hopefully you guys will follow us, and hopefully you find all of that rewarding. Trying to respect time. I think I'm at 80 minutes. So I want to say thank you. And I do sincerely hope that this was informative and enjoyable. I wish everybody on this call a wonderful evening. And I can't thank you enough for spending the time with us tonight, me being a presenter and Ormco being the host. I think that that's a wonderful relationship. In closing, I would just say that if you like what you saw, I can tell you that there is zero trickery in any of this. The reason that I spend so much time putting these slides together, and the reason I spend so much time trying to put something together that makes sense is because this is such great technology, and it's too good of a secret to hold. So I hope that this can be shared worldwide, and I hope that everyone on this call can do it. So thank you very much, and have a good evening.
Thank you, Dr. Bicknell. It is a wonderful partnership. We are lucky to have you, and your ability to show the excellence in finishing and your ability to take us right into the heart of the bracket is appreciated by all, I'm sure, tonight. We do have a few questions. Let's try and fire through these as quickly as possible. I'll try and group together if that's okay with you, yeah?
Yeah, that's
Good, good. So the first one is a simple one in terms of what tubes do you use with the Ultima system? Do you still use the original Damon tubes, or is there another?
Yeah, I do. I never really liked the SL tubes on the sixes. For me, it didn't work because if the SL tube opens up and you're really preaching for efficiency, then if the SL tube isn't fully closed or it opens, the tooth rotates and it takes months to get that back. So I've always used regular tubes. The tubes that I have that you saw in all my cases are the titanium tubes that are made from Ormco in the Damon prescription. So that's the answer to that. I use the lower 6 full, the lower 7 full, the upper 6 full, and the upper 7 full tube titanium tube.
Fantastic, thank you. And if anyone wants to get hold of those types of tubes, please contact your local Ormco rep.
And one thing too, they fit in the box. So the nice box that fits all the braces, they have those in the sticks that fit right in there. So it's not like you have to pull those out of a bag or anything. They're made for the Damon system, but it's the titanium tube.
That's right. So let's move on to some torque questions. A couple linked in terms of the use of neutral torque. Obviously, you've talked about that in great depth, but someone's asking: can you use neutral torque for canines if the torque is fine, like doing Q2? And when is neutral torque any option? Or when is it used at all?
So it's a great question. And interestingly enough, my answer changes as we go through this journey. So where that answer stands now is that if you have a really nice torque on a tooth, then yeah, it makes sense that if you put a neutral torque bracket on it, it's just not going to engage a torque couple, right? So you're probably just leaving the tooth where its original position was. The problem with using the neutral torque bracket is you're giving up the second order control, because if you have an 022 vertical slot on the neutral and you put in your 180275, you still have 4/1000ths of play in the axial. So literally, the reason you would choose a variable torque bracket in a canine or any tooth that has a perfect torque angulation is because you're trying to gain second order control from that variable torque. Now, can you guess wrong? Not really. If the tooth's in the right spot and you put a high or a low on, it's just going to be passive. And if you guess completely wrong, then it's neutral in the opposite way. So for me, if I look at a case and I see that canines are fine and I can't figure out at all what is going to help, I pick the opposite torque of the one next to it, because that's going to team them together, which means, let's say I have a lateral that's palatal and I know that the lateral root needs to come forward. So I put a retrocline torque on the lateral incisor, but my canine's perfect. I'm going to put a procline on the canine because that's going to engage in an opposite direction of the lateral. So that's the whole torque teaming idea, right? So I can tell you that from an inventory standpoint, I only carry pro and retro in the anterior. We don't have any neutral torque brackets in the practice, and I don't think I can think of a reason why I would use them, knowing what I know now after probably putting on 2,000 sets.
Thank you. I think that's pretty clear. I hope that answers your question.
Can I explain one thing though? So the other question that maybe, I don't know how many people are on the call. I think it's quite a few, but there's got to be more than 100 people that are asking in their mind, well, why did they make neutral torque? I'm a big fan of like opening up the elephant in the room. I talked to Dwight about this, and Dwight said the reason that they made neutral torque was because 70% of the global market uses standard torque DQ2 brackets. And of the 30%, variable torque is used routinely, right? So think about this. If you're a standard torque bracket user and Ormco comes out with their new greatest system and they only tell you that you have to use pro or retro, you're probably not going to utilize it. But if they just went to neutral, they would actually be better off because now they at least have first order control and they have a better wire. So I think the whole idea is that when you're a manufacturing company, you have to still satisfy your customer base, even if it slightly upsets the base that figures it out later. Because I can tell you, when I see neutral torque brackets on cases now, I'm just shaking my head. I'm like, ugh. Like I might have to do a tiny bend in the second order. So hopefully that helps.
Yeah, thank you. Every little bit of information helps everyone. So let's move on to bracket positioning and bonding protocols.
Sure.
Just quickly, someone tuned in a little bit later, so maybe you could give the bonding measurements for Ultima. Are they the same as Q2?
Yeah, they are. I mean, at the same, I didn't really change where I put Ultima in Q2. The only difference is that Q2 I would cheat here and there. I would put if you eliminate cheating of the bracket, meaning that if you have a canine that is going to have rotational play, we would always put our canines about 1 millimeter mesial, and then our lower laterals about 1 millimeter mesial. If you had a pro and a retro next to each other, you would offset them because the vertical was different. If you eliminate all of that, then the values are roughly the same because the base of the Q2 bracket or the pad is the exact same pad as the Ultima bracket. It's designed to be at FA point, which is about 5.5 millimeters from the incisal edge on a central, about 5 millimeters to 5.2 millimeters on a lateral, and about 5 millimeters on a canine. As you walk back, you can do measurements. I think it's 3.8, 3.2, and 3.2, but I don't measure posteriorly. What I do is I put my 6 or my first molar on at FA, and then I line up my second bicuspid with the slot of the 6, and then I add my first bicuspid so that I see a little bit more cusp tip from the cusp tip to the bracket base to start beginning the wedge. And from there, then I go 5, 5.5, or 5, 5, 5.5. And on the lowers, it's 5.5 on your canines from the incisal edge, the slot, and 4.5. So let me do, you can still see my screen, I think. Okay. No, I don't have that. Okay. Yeah, I thought I had something that showed that, but no. Hopefully that answered the question.
Yeah, can you just confirm your position for the premolars and molars just again?
So again, I don't measure from the premolars and molars. I know Stu, Dr. Frost does, or at least he shows the measurements for that. I think from the molar, it's 3.2, and then I think the second bicuspid is 3.2, and then it's 3.9 or 4.0 on the first bicuspid. I particularly look at FA point on the molar as where I position my first molar. Second molar, I actually position as occlusal as possible because I want to get the second molar cusp tip up. The second bicuspid, I position so that my slot is in line with the first molar, and then my first bicuspid, I position so that I see a little bit more cusp tip from the base to the incisal edge. That's how I position all posterior brackets. I had a whole kind of thing about that, but we just ran out of time.
Maybe next time. Just a few more questions. We'll move on to elastics. The question of early elastics is in there. And the quick pop question is, when do you use elastics now with the Ultima?
So I've reduced significantly the amount of early elastics that I use. I use early elastics for cross bites. I just like getting the posterior unlocked. So if I use a disarticulation and then I put a button on the upper first molars, I'll always run like a 3.5, 3/16 crossbite elastic from day one, simply because I want to start developing the upper transverse. The second cases that we run early elastics on are class 3 with anterior crossbites. It's the exact same reason. I want to get that anterior crossbite corrected as quickly as possible so that I can make the patient comfortable and prevent wear on those front teeth. The only other time I use early elastics is in a class 2 case where I still have the upper second deciduous molar present. what we do is we put a hook on the floor, we start a class 2 elastic, and then we have those baby teeth extracted. And what that does is that slides the first bicuspid distal into the space of the E-space, fixing about 2 millimeters of the class 2 with just some simple math. Other than that, we don't use early elastics at all anymore. We wait until the third visit when we place the 140275s. That's when we start our class 2s, class 3s, things like that.
Fantastic. And let's just finish off with a couple of questions on wires, and particularly the final wire. First question is, I'll do both questions at once. What is the minimum time you keep the 18275 stainless steel in for, and how do you hold space together with that wire in the front?
All right, so that's, again, great question. I had some good slides for that, but just ran out of time. The final wire that you choose, whether it's NiTi, whether it's steel, whether it's TMA, or if it's even an overdrive, it's dependent upon what you need. Meaning, if I have space distal to the canines and I'm using a steel wire in the upper in my phase 3, I'm going to use a retraction coil from the post to the 6, and that wire is going to stay in until that space is closed. Once that space is closed, I take the retraction coil off and I use a tieback module, which is an Ormco product. It's kind of like a C-chain that's got 2 little loops on it with a connecting rod. And you can get those from your reps. I replace that NiTi coil with a tieback module, and then I keep those tieback modules on until I'm finished. Now, sometimes if the case looks great out of NiTi, I just set up Devon and take braces off 4 to 6 weeks later. So really the NiTi is only in for about 4 months. If I have to transition to steel, if the spaces are closed, then I may keep it in for arch development or AP correction. Again, once AP is corrected, the arch is developed and the spaces are closed, braces come off. So that could take, that may take 2 months, that may take 7 or 8 months, right? If you've got a really, really tough class 2. And lastly, if I have, and I know a lot of docs I talk to in the UK have some really, really deep bites. Sometimes in a 160275 steel, I'll add some reverse curve to the steel wire. When I add that reverse curve, I'm not bending it, I'm just shaping it. So I'll allow that to work itself out until the AP is corrected, because we all know that you can't fix a class 2 unless you level the lower arch. So the answer is I leave those final wires in until they're done. It sometimes varies 2, 3, 4, 5, 6 months, but I can tell you I'm not bending them. So I'm not using the wires to manipulate the tooth into position. Once I put those final wires in, the anterior segments look great. Now, the second part of the question, how do I keep anterior spaces closed? Previously, I was using lacing. I would lace upper 321123 with a piece of 009 steel ligature, and I would do it under the wire, and it would just stay there. Now we're using the new Damon Ultima hook, which I don't know if it's available yet, but that Damon Ultima hook has the ability to slide up against the distal of the canines. That prevents us from having to lace the anterior segment, but it's movable. So if I have to, let's say, IPR between the upper centrals for a gingival triangle, and I put C-chain on, I can then take the Damon Ultima hooks and I can move them into position. So, but that's something that I don't know if you guys have access to yet, but I think it's probably over the next few months you guys will.
Yeah. Thank you, Dr. Bicknell. That's all the questions for tonight's session. And thank you for taking the extra time. And thank you to all of you in the room who have taken extra time just to listen to the answers and to learn as much as you can about the Damon Ultima system. Dr. Bicknell, we hope to see you again soon. Thank you for your session tonight, and we appreciate all the hard work you've done.
Yeah, I wish to thank you guys for having me. Everyone have a great night.
Thank you. And just to let you know, everybody, there is a session coming up in a few weeks' time. The next session is with another one of our speakers, Dr. Bovenizer. It's on the 16th of May, and it will continue this excellent journey on the Damon Ultima system and how to get the best out of passive self-ligating. So, thank you again, everybody, and I wish you all the very best, and good night.